From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to JAMA Clinical Reviews. Thank you for joining us. I'm Dr. Mary McDermott, Deputy Editor of JAMA, and I'm here today with Dr. Robert Kushner to discuss his Obesity Insights article in JAMA, which reviews what clinicians need to know about diet and physical activity recommendations for patients taking incretin-based therapies for obesity. Dr. Kushner is Professor Emeritus of Medicine and Medical Education and former Director of the Center for Lifestyle Medicine at Northwestern University's Feinberg School of Medicine. Welcome, Bob. Thank you so much for joining us again.
Thank you, Mary. Pleasure being here.
Can you start by just reviewing the relative amounts of weight loss for the incretin-based therapies versus the traditional behavioral strategies for weight loss?
Sure. The phase 3 trials that we did for both semaglutide and tirzepatide, the average weight loss or mean weight loss, about 15% with semaglutide and about 20% with tirzepatide after about 68 to 72 weeks. That's in contrast to what we see with intensive behavioral therapy alone, which is typically 5 to 8% weight loss.
And your article talks a bit about how these therapies like semaglutide and tirzepatide have changed how we think about behavioral strategies, diet and exercise for patients working on weight loss. So can you just talk about that a little bit, please?
Yeah, over the years, the workhorse for weight management has traditionally been intensive behavioral therapy, which translates into about 14 or more in-person visits with a trained professional over 6 months. In fact, CMS, Centers for Medicare and Medicaid Services, has adopted intensive behavioral therapy that all clinicians can code for, which asks for a face-to-face visit every week for the first month, one face-to-face visit every other week for months 2 to 6, and then every month thereafter, because that's how important it is. That's what we've always used. But with the arrival of these highly biological incretin-based medications, we are rethinking how much intensive behavioral therapy is needed. In fact, whether we even need intensive behavioral therapy with the use of these medications. And that is really transformative of how we think about providing obesity care.
So what evidence is there about how best to combine diet and exercise with these incretin-based therapies?
We're still learning a lot because the key evidence-based studies have not been done. But one of the studies that was conducted that has questioned the importance of the intensity of intensive behavioral therapy were called the STEP trials with semaglutide. In STEP 1, for example, 18 brief lifestyle visits were conducted over those 68 weeks, which led to a 15% weight loss, which we just said. In another STEP trial, we added 30 visits, which would be this intensive behavioral therapy. And you know what? We only got a 1% greater weight loss despite adding all this intensive behavioral therapy. And that really questioned, does the clinician really need to provide this intensive behavioral therapy to get that kind of weight loss? And finally, there was that one head-to-head trial of semaglutide and tirzepatide. It was called SURMOUNT-5, in which only 9 visits were provided over 72 weeks, which is really quite doable in an outpatient setting. And in this study, patients on semaglutide lost 14% of their body weight, and those on tirzepatide lost 20% of the body weight. But what it really questions or challenges is we can get by with less intensive behavioral therapy, and we'd call it more moderate lifestyle therapy, and still get this effective weight loss in patients we're treating for obesity.
So given what you've just said, do clinicians even need to ask about dietary intake? What are your thoughts about that?
Yeah, good question. So it is not to mean that lifestyle therapy is not important. It is absolutely important. We need to provide lifestyle therapy for multiple reasons. One is to mitigate or reduce the GI side effects that's seen with all incretin-based therapies. We need to promote health, which gets to increase physical function, helping muscle mass and bone health, preventing vitamin and mineral deficiencies, and targeting treatment of obesity-related complications like cardiovascular disease and diabetes. So key take-home message, lifestyle counseling is extremely important. The real question is, how intensive does it need to be to get the same amount of weight loss we saw in the phase 3 trials?
Yeah, and it feels like based on evidence, it can be less intensive.
We think it can be less intensive, but nonetheless very important for overall health. So when a clinician sees a patient on incretin-based therapy, it is extremely important to take a diet history and physical activity history and provide counseling for that patient.
Let's take that a little further. So specifically, what diet questions do you ask? Probably not about the quantity of food, perhaps, but what questions should clinicians be asking these patients?
Before these drugs came about, we would spend our time trying to reduce calories, limit your portion sizes, go longer periods without snacking all the time. We don't need to worry about that anymore because the medications work biologically to do that. So we're shifting now to really the quality of the diet and dietary patterns. So the type of questions you're asking when you're taking a diet history is describe a typical day of your eating, including your appetite, meal regularity, the content of each meal. Do you snack? If so, what's the content and the frequency? You want to also talk about what's your protein intake and your fiber intake. How much water are you getting? Are you having any food intolerances or symptoms that limit food intake because of the GI side effects or reduction in cravings of food? You also, depending upon the vulnerability or age of the individual, assessing vitamin nutrient deficiencies through diet history, calcium, vitamin D, iron, and potassium.
And talk a little bit more about protein. How much protein should patients on incretin-based therapies be getting?
Well, we know to maintain muscle mass, and that's what we're really concerned about, and you're not eating as many calories, you want to have a high protein diet. So that translates into an intake of about 60 to 75 grams of protein per day, or we can do it on a per kilogram basis, which is 1.2 or 1.5 grams per kilogram. So you have to do a little math there. And you want that from high quality protein sources such as lean meats, fish, eggs, low fat dairy products, legumes, and soy. That's really what we're emphasizing. So it's a little bit more plant based. If you're having animal products, you'd like that to be lean protein sources.
Would you say there's good evidence for telling patients to focus on protein, or it's more a theoretical approach?
We have data from multiple other approaches, whether it's diet and lifestyle alone or bariatric surgery or the earlier medications, that higher protein diets, when combined with vigorous exercise, particularly resistance exercise, you can help to maintain your muscle mass. And that's really what the goal here is, to remain fit and functional and strong.
Can you talk a little bit about the recommendations you give if a patient's having adverse effects like nausea, for example, from the incretin-based therapy?
Yeah, great question, Mary. And I always tell clinicians, before you write your very first prescription, you want to provide guidance on how to reduce side effects, because almost everyone is going to have some level of GI side effects: nausea, vomiting, diarrhea, constipation. So the key recommendations that we learned from the phase 3 trials is to reduce portion sizes, don't overeat. As soon as you start feeling full, stop eating. Reduce greasy or fatty foods. Keep yourself well hydrated. Reduce alcohol and carbohydrate beverages, and plan your meals every day. Since these injections, which are provided weekly, the peak effect of the side effects are usually within the first 24 to 48 hours. Be very thoughtful where you're going to be eating over those first 1 to 2 days after your injection. So you don't want to take an injection and go out and party for the next day or two, or go out to your favorite restaurant that it's hard to refuse what is special of the day is. You're likely not to tolerate it as well.
How about fluid intake? What do you ask about that, and what amount do you want the patients to get?
You certainly want to talk about where to get your beverages. Are you drinking fluid? Is it water, carbonated beverages, or flavored beverages, and so on? The general rule of thumb is 64 ounces a day, which is 8 glasses a day. That's really not based on hard science. Food has water in itself as well, like fruits. But you really want to be drinking fluids throughout the day. And Mary, you and I know you could ask a patient when you urinate and make sure it looks clear to prevent dehydration, as an example.
And why did you mention flavored or not? Why is that important?
People often taking flavored water now, that's all. Not just water, but flavored water beverages.
Okay, but no concerns about that.
No, not at all.
Okay. Let's talk about physical activity a little bit. What do you ask about physical activity and what do you recommend?
Well, just like we need to take a diet history, we need to take a physical activity history, such as what are you doing in the course of the day? How much walking do you get in the course of the day? Are you doing any programmed exercise, which would be aerobic activity or resistance training? You want to ask about any sense of weakness or fatigue in the course of the day or muscle strength. Getting up from a chair, picking luggage up when you're on an airplane in the upper bins, kind of get a sense of strength. So you want to ask about that. And you want to emphasize that it is important to remain physically active and even begin resistance training exercises because of what we talked about regarding muscle health.
And are there some exercises for resistance training people can do at home and don't have to have a gym membership?
Absolutely. Resistance bands is something you pick up anywhere that you could put it on furniture or put it on your foot. They come with instructions, but you could isolate each of your muscle groups, arms, legs, quadriceps, hamstrings, and so forth. You could do push-ups, you could do squats, things we did probably in grammar school, where you could actually start doing that. So you could actually do that without having to go to a gym. However, I will tell patients who find it challenging to begin a resistance exercise program, and they could afford it, to consider getting a personal trainer because that's how important it is when you're losing 20% or 25% of your body weight.
Interesting. Is it harder for patients to follow diets high in fruits and vegetables when they're on these medicines?
Not necessarily. There's a change in cravings. Anyone who's treated patients with increment-based therapies, I think, are impressed with how the diet changes, the preference of food changes, and cravings change. Individuals who never ate fruits and vegetables before are now starting to eat fruits and vegetables. Patients who couldn't stop eating cookies and candies and cake are now stopping to eat it. So the heavy lifting is actually done by the medications. What you as a provider need to do is to provide counseling on healthy eating patterns.
And then for patients who are not able to continue these medicines for whatever reason, financial or adverse effects, what recommendations do you give to help them maintain any weight loss after they're off the medicines?
It's a very important question, and we need more evidence for that. But using best practice, which we've learned from all of the behavioral trials that go back for 30 years or longer, we talk about healthy eating patterns, monitor your diet and your weight, have a plan of action on every day of what you are eating, increase fruits and vegetables, reduce your energy-dense foods. Stay in touch with your healthcare professional for accountability and guidance. Even a referral to a registered dietitian could be very helpful at that point. It is, I think, a mistake for the clinician and the patient to think if you're going to stop these medications that you can continue the weight loss or maintenance on your own. It's very challenging to do that because the appetite change that occurs with the medications will be gone. And it's very common that appetite returns, cravings return, food noise comes back, which is this incessant thinking about food, and people start to consume more calories.
I'm Dr. Mary McDermott, and I've been speaking with Dr. Bob Kushner about lifestyle changes in conjunction with incretin-based therapies for weight loss. You can find a link to this article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.